Ladies and gentlemen, good morning, or good afternoon, or good evening, depending on your location from where you are tuning in to this webinar. I'm Dr. George Mensah from the National Heart, Lung, and Blood Institute, which is part of the United States National Institutes of Health, NIH, where I serve as Director of the Center for Translation Research and Implementation Science. I'd like to give you all a very warm welcome to today's webinar. This webinar, as you know, is jointly sponsored by the Journal of the American College of Cardiology and the National Heart, Lung, and Blood Institute. We are just delighted to have you with us for what I think will be a very stimulating and insightful discussion on the social determinants of heart health at the regional and national levels. We're going to be exploring the socio-demographic impact on cardiovascular mortality. In today's session, we will take a really deep dive into some of the most critical issues in cardiovascular health, guided by the latest socio-demographic index data from the Global Burden of Disease, the GBD 2022 study. There are a few objectives that we would like to accomplish by the end of the webinar. First, we're hoping that our panelists would help us identify the major insights from the global burden of disease data, especially on age-standardized mortality rates for cardiovascular disease across regions that have varying socio-demographic index scores. Second would be to highlight the key social determinants of health that contribute to disparities in cardiovascular outcomes across these regions, and then also explore some examples of how many governments are leveraging these socio-demographic data to inform public health interventions and strategies and target cardiovascular disease treatment and control, and also prevention. Finally, we would learn how the American College of Cardiology is addressing these social determinants of health, both here in the United States and in its partnership with international heart health organizations at the global level. We are very, very fortunate to have several leading experts from across the cardiovascular health community to address these objectives. And we are confident that today's webinar will leave you with real practical insights and strategies to drive meaningful progress in reducing cardiovascular mortality globally. The four outstanding panelists we have include Professor Glaucia Maria Moraes de Oliveira. She's Professor of Cardiology at the School of Medicine and the postgraduate courses in Cardiology at the Federal University of Rio de Janeiro in Brazil. She's also a cardiologist with a very strong focus on population research. She's significantly contributed to understanding cardiovascular disease epidemiology and the role of social determinants of health. Second, we have Dr. Melvin Echols, who is Chief of the Diversity, Equity, and Inclusion Office at the American College of Cardiology. He leads the college's diversity, equity, and inclusion strategy and programs, while also maintaining a portion of his current clinical and research responsibilities at the Morehouse School of Medicine in Atlanta. Our third panelist is Dr. Rosanne Freak-Poli. She's a Senior Research Fellow at the School of Public Health and Preventive Medicine and the School of Clinical Sciences at Monash Health in Victoria in Australia. She's also a life course epidemiologist who has focused on social determinants of health. And last, but certainly not the least, our final panelist is Dr. Eugene Yang. He's a clinical professor of medicine in the Division of Cardiology at the University of Washington School of Medicine. He also holds the Carl and Renee Benke Endowed Chair for Asian Health. Dr. Yang is immediate past chair of the American College of Cardiology in the Prevention of Cardiovascular Disease section. So as you can tell, we have a lot of experts and we have a lot of ground to cover. So let's dig right in. Eugene, I introduced you last, so let me begin with you. Now, prevention and the overall burden of cardiovascular disease has been very central to your professional efforts. And although we're going to focus on socio-demographic index, it's really important for you to tell us, what is the central message about cardiovascular disease prevention that you would want to emphasize across all regions, regardless of the socio-demographic index status?
Well, thank you, George, for inviting me to participate in this fantastic session. You know, I think irrespective of the socio-demographic index that we're going to focus on, all of these things really relate to cardiovascular disease risk factors, and ultimately, how do we prevent cardiovascular disease? So regardless of what region of the world you live in or what state in the United States you're residing in reality, what we really need to focus on are the important things regarding prevention, specifically awareness about the risk factors, detection of the specific diseases that are associated with cardiovascular disease. Furthermore, we need to be able to evaluate the patients appropriately and then offer appropriate treatments. And that's really the focus and central theme around all of the things we're going to be talking about today. I think secondly, it is important really to recognize the importance of the strategies that we use for both primary and secondary prevention. As you know, we have many clinical guidelines that have been published by the American College of Cardiology, as well as other societies, that really should be the driving force behind how we manage and treat cardiovascular disease.
That's terrific. So, Rosanne, given what we just heard, and recognizing that these risk factors and the guideline-directed care are important in all regions, we also know that the social determinants of health play a crucial independent role. So what insights did we learn from the GBD study about the burden of cardiovascular disease in these regions, especially the regions with low socio-demographic index compared to those with high socio-demographic index?
Thank you for having me today. What stood out for me in the report was that within each geographical region, there was a wide range of age-standardized mortality rates, as well as a wide range of socio-demographic index countries. However, the high socio-demographic index countries were clustered together and tended to have the low age-standardized cardiovascular disease mortality rates, despite their geographical regions. So this demonstrates that national wealth is greatly influencing cardiovascular disease mortality. National wealth can be considered a social determinant, and the World Health Organization defines social determinants as the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. We know that social determinants account for between 30 to 55% of negative health outcomes. Now, to discuss change over time, in high socio-demographic index countries, there has been a decline in age-standardized cardiovascular disease mortality rates. However, this does not necessarily translate to a decrease in cardiovascular disease burden. The report demonstrates that some high-income countries have had increases in cardiovascular disease burden due to population growth and aging. And I know that in Australia, what we have found is that we rank at around 13th out of 204 countries in our rates for the age standardized mortality rates of cardiovascular disease. But we still have a really high number of incidence rates, and we only rank 139th. So we're doing really well at keeping people alive once they have an incidence of cardiovascular disease, but we're not necessarily preventing them, which is the issue. Now, when we look at changes over time in low and middle social demographic indexed countries, there has been an alarming rise in cardiovascular disease burden. They're faced not only with population growth and aging, but also an adverse trends in major risk factors. So in all countries, despite their socio-demographic index, addressing social determinants would improve cardiovascular disease health, as well as influence the environmental, metabolic, and behavioural cardiovascular disease risk factors that are in the report.
That's really very, very helpful. And Glaucia, I mean, we just heard the example from Australia, and I want to bring in Brazil and South Africa. Both of these countries are classified in the high middle socio-demographic index category, but the age-adjusted mortality rates are quite different. For example, the difference, in fact, is even more stark when you look at Belarus and Chile. Both have high middle status, just the same as Brazil and South Africa, with a socio-demographic index around 77 and 78. But the age-adjusted mortality rates per 100,000 is almost fourfold difference, about 459 versus 114, respectively. So what are the major drivers of these huge differences that we see in pairs of countries that are in the same category, but have such difference in outcomes in terms of mortality?
Excuse me. Thank you for the invitation. George, this is an excellent question. Dr. Freak-Poli told us about the divergence in CVD trends based on the SDI levels. It's reasonable to understand that low and middle SDI countries had an alarming rise in the CVD burden, especially related to premature death, secondary to significant risk factors. On the other hand, it's a little more complex to understand how middle SDI countries with so different age-adjusted CVD mortality. In the first comparison, we have Brazil and South Africa, both BRICS countries and emerging economies, listed among the most unequal countries worldwide. Suppose we use it, for example, the Gini coefficient. South Africa has a higher Gini coefficient at 63%, the latest measure 10 years ago, and 5.2 in Brazil in 2022. Also, it is essential to know that in Brazil, SDI was formally pushed by the South and Southeast region that had almost 40% of the Brazilian population, being the richest geographic region of the country. And South Africa has the Gini coefficient dropped because approximately 55% of the population is living in poverty. Also, most of the populations in both countries depends on the public health system. In addition, the Brazilian public health care improves healthcare access and quality, facilitating the management of key risk factors such as smoking, alcohol use, hypertension, and obesity. Maybe these factors can explain the lower mortality rates in Brazil. The comparison between Chile and Belarus is quite different because both had different Gini coefficient, 45% and 24% respectively, with more significant mortality associated with a low Gini coefficients. Cardiovascular disease mortality rates had decreased significantly in Chile, in both FACCs, especially in women. This decrease could be explained mainly by a significant reduction in case fatality in recent decades. These results were probably due to development of primary prevention and acute management of CVD policies focused on population with high mortality, addressing the population aging. On the other hand, Belarus, the life expectancy, particularly for men, remains relatively low compared to the other European countries. Belarus smoking among men remains a severe health system, and this prevalence is one of the highest, 48% in Europe. The level of physical activity among the population remains low. Only a quarter is involved in physical activity. Also, Figures suggest that there is a correlation between alcohol consumption and suicide rates in Belarus, ranking in the top 10 worldwide, probably expressing the role of psychosocial stress in this population. In addition, Belarus' demographic transition shows the crossover between the crude birth rate and the crude death rate, where the natural rate in population increases negative. Low fertility and rising average age might lead to invert population pyramids, which will be fiscally and socially challenging. Economists have pointed out potential links between a slow economic growth rates, aging population, and stricken workforce, all as a driver for CVD outcomes. All these factors can probably contribute to high mortality rates in Belarus.
Yeah, no, that's extremely helpful, and obviously it lays out the complexity of the biomedical factors as well as the social and psychosocial, socioeconomic factors, all really playing a role. Melvin, let me bring you into this discussion and mention that very often we assume that the high income countries or the high socio-demographic index countries are doing much, much better than the low socio-demographic index. In fact, the observation for Japan and the United States, both high socio-demographic index countries with an index of 87 and 86 respectively, but Japan's age-adjusted cardiovascular mortality rate is about half of what we find in the United States. So what are the major drivers of the differences between these two mortality rates?
Great. Once again, thanks again for having me. And, I think this is a wonderful platform to discuss this topic, primarily because looking at Japan and looking at America, there are some significant differences here that I think we should consider when we're looking at these mortality rates. And one of them is actually culture. So culture among Americans is quite heterogeneous and a wonderful mosaic of all people, whereas it is pretty much homogeneous in Japan. Now, why does that matter? Well, culture actually dictates a lot of what people do at times in terms of their behavior, their risk factors. So when we look at obesity rates, you can look at Japan, where their culture actually values physical activity, a lot of walkability, in areas. And so to that end, you have obesity rates that are about 4% compared to, some places in rural rural America that can be as high as 40%. I say North Carolina because I'm a rural North Carolinian. And so I understand these issues that bring us to the next level of what the challenges happen to be in terms of the differences. And that's the social determinants of health as they relate to healthcare access. And so, when we look at Japan compared to the USA, the access is a lot more sort of customized for the entire, country, as it were, whereas there are certain people or certain groups of people in America that actually face access challenges differently. And so, for instance, African Americans in America have had problems with access for quite some time, as well as issues that have affected their health that have related from structural determinants of health that, again, sort of all compiled to actually cause problems in terms of the risk factors, such as hypertension, which is the number one, global killer in the world, in terms of cardiac risk factors. And that is just, unfortunately, heavily prevalent in the African-American population, which, again, to that end, culture dictates how well we are aware of these issues. And again, unfortunately, a lot of people are not very aware of their blood pressure, and they're not very aware of the insight in terms of trying to treated. And so those are some of the major problems there. I think, you know, lifestyle factors overall, I think there's just more of a physical activity for people in Japan compared to people in America, just, you know, in general. And then just, again, cultural attitudes. You know, as I said, cultural attitudes dictate a lot of what the population of the people will do. And I think Japan just has a better culture attitude of health in terms of decreasing unhealthy foods. Their overall diet itself is dramatically different from ours, but actually it's promoting very good quality nutrients as opposed to some of the things that Americans tend to eat for their regular diets. But then again, the last thing you have to think about, you know, social determinants of health and how this all like plays into sort of these challenges. And there are things here called food deserts in America, where people are living in places where they cannot get the proper produce or great food that might be, you know, good for their health, and so they're stuck with what they have. I can attest to that firsthand as a growing up a person in the rural areas of North Carolina. So I will say that, and I will say it's highly complex, but I think we can all learn from these differences, and we gain more from our similarities than we do our differences.
Excellent. That's one of the real values of these global burden disease studies, that looks across multiple regions of the world. And I'm really glad you mentioned hypertension. And Glaucia, let me bring you in here because high blood pressure is the dominant preventable risk factor across most regions. So could you briefly share with us, in what ways does it disproportionately impact countries with lower socio-demographic index that would be similar to the low resource settings that Melvin just mentioned in high income countries?
The number of people with hypertension worldwide, it has doubled since 1990, with most of the increase occurring in low and middle income regions with low STI. In high-income countries, prevalence has declined, while health systems have achieved treatment rates up at 80% and control rates up to 60%. Middle-income countries in Latin America, East and Southeast Asia, and Central Asia, the Middle East and North Africa have also enhanced the detection and the treatment of hypertension. Low detection and treatment rates persist in the world's poorest nations, especially in sub-Saharan Africa, Oceania, and South Asia. Together with the increasing number of people who have hypertension, this low detection and treatment rates will shift as an increased share of the burden of the vascular and renal condition of these regions. Preventing hypertension and enhancing its detection, treatment, and control is feasible not only in high-income countries, but also in low-income and middle-income nations. The use of non-physician health workers and patients follow-up using text messages, for example, can improve hypertension care. Reducing salt intake to prevent hypertension might be possible through a combination of physical, regulatory, and possible behavioral interventions. Increased availability and consumption of fruits and vegetables partly account for the observed decline in hypertension, which indicates that making these foods affordable and accessible might be effective for hypertension prevention. For example, the expansion of universal health coverage, like in my country, and primary care in places with low rates of diagnosis provide an opportunity for improving hypertension care. Wider availability of treatment and lower cost of antihypertensive medication is crucial. Programs should also be regularly assessed, both of the population level and in health, facilitating facilities to ensure accountability and stimulate improvement in control of hypertension.
Good. It's good. Rosanne, maybe if you could add a few additional strategies that are likely to have the most impact in addressing cardiovascular disease burden, especially in low and middle socio-demographic index countries. If you were to give us 2 or 3 more, what would those strategies be, for example?
Well, we know that there is consistent evidence that early childhood development, economic circumstance, the social and community context, as well as the neighbourhood and built environment all play significant roles in cardiovascular health. So addressing any of those would be beneficial. I believe that we need structural changes that address these social determinants at all stages across the life course. Policy intervention should start when the child is developing in the womb and continue to later life. Now, as both Glaucia and Melvin were discussing, many of these risk factors are complex and intertwined and grouped together. Social determinants are no different, and it's preferable to address these simultaneously. The breadth of social determinants factors linked to cardiovascular disease identified in my research implies that addressing one factor in isolation may not make a huge difference. So in low and middle socio-demographic index countries, it may not be possible to undertake complex or simultaneous interventions. Therefore, targeted strategies focusing on social demographic factors and social determinants specific to the region would be a good start. This could be an intervention addressing one risk factor promoted to the entire population, or alternatively would potentially one or more interventions aiming to address several risk factors in a sub-cohort of the population. It's a good start. Now, in high socio-demographic index countries, the focus should be on strengthening primary healthcare systems and public health prevention strategies by integrating social determinants. In all countries, or in many countries, there are medical professionals undertake cardiovascular disease risk score assessments and then assess how they can address this high cardiovascular disease risk at an individual level. However, many of these risk scores do not assess or incorporate social determinants, which could improve risk prediction. As social determinants influence and often occur before all the metabolic risk factors that we see in the report, this would also bring cardiovascular disease prevention earlier in the life course, so to younger adulthood. A really exciting initiative that's more recent is social prescribing. And social prescribing provides the opportunity for healthcare providers to refer a patient to a link worker. A link worker has the time and ability to co-design a plan with the patient that addresses the social determinants that they're facing. It connects the patients to non-clinical supports and services within the community to improve their health and well-being. Now, social prescribing leverages existing health, societal, and community systems to address the social determinants and psychosocial factors that Glaucia was discussing, affecting, but also possibly exacerbating their cardiovascular risk.
Yeah. I love the concept of social prescribing. You know, when you mentioned it, it just reminded me of Dr. David Satcher, former U.S. Surgeon General, who really popularized the concept of physical activity prescribing. You know, it's very easy for clinicians to prescribe drugs, but rarely do we prescribe physical activity or prescribe nutritional interventions. So social prescribing, that's really terrific. So Eugene, let me challenge you here. Is anybody listening to us? You know, it's one thing to publish these data in JACC and make it available to everyone, but are governments listening? Are governments taking advantage of this? I know your institution, University of Washington, is home to the Institute of Health Metrics and Evaluation, and I think it's done a terrific job with making progress in developing these health estimates. But Are there examples of countries that are actually taking these data and whether they're doing social prescribing or population level interventions are really beginning to use the data to inform the management and the prevention and treatment and control of cardiovascular diseases? Could you give us one or two examples of where this has worked at the country level?
Yeah, so George, I mean, I think I'm very fortunate to be here at the University of Washington, the home of IHME, and furthermore, one of my colleagues, Dr. Greg Roth, who really has led these efforts. So he and I have had many discussions about the breadth and the scope with which IHME, working on GBD, has really partnered with many governments around the world. So I think his travel to these countries to discuss the data that has been published has really been fruitful in terms of really providing many governments, whether they're low, middle, or high SDI countries, with information that has given them an opportunity to address some of these things that we've all discussed. So, you know, one example for a low SDI country, for example, like Rwanda, the Rwandan Ministry of Health really used some of the data to identify, which we've already acknowledged, the importance of hypertension and its role in cardiovascular disease mortality, also identifying that within their country that there's untreated hypertension leading to a high rate of stroke and heart disease in the country. So that allows that country, Rwanda specifically, to enact some policies specifically to address hypertension and its association with cardiovascular mortality. Another example is Mexico, which is a middle SDI country, and that country has also used the data that's been provided through the GBD and IHME to address, for example, dietary risk factors, similar to things that we've done here in the United States, implementing a sugar-sweetened beverage tax, which they did introduce in 2014, also looking at front-of-package labeling and efforts to try to identify people who are eating processed foods that are high in sugar, sodium, and unhealthy fats, obviously encourage individuals to make healthy choices in terms of their dietary habits. And then finally, if we look at high-income countries like Australia, where Rosanne is, the Australian government has also used some of the GBD data to address health inequities, and I'm sure she's familiar with some of these programs or initiatives, including tackling Indigenous smoking programs, better cardiac care for Aboriginal and Torres Strait Islander people. So clearly the governments are paying attention to some of these things. I think obviously the challenge is that we have hundreds of countries, in trying to engage all of them with the data that's being collected by IHME and through the global burden of disease, I think remains a challenge. But clearly there are examples of how the data has been used to initiate policy initiatives that have been beneficial to the populations at risk.
That's fantastic to hear. Melvin, let me ask, you know, we heard about the role of governments. We all know about the roles that academic and community health centers play, but the professional societies also have a role. So let's hear from you. How is the American College of Cardiology addressing social determinants of health at the U.S. national level, but also in their partnership with the international health organizations? How are they addressing this at the global level?
Okay. Well, first of all, how much time you got? No.
we'll give you a full 2-3 minutes. How about that?
All right. Well, so first of all, you know, this is one of my, you know, most passionate things that I do here. And so, you know, it's so important to get everybody to understand, you know, the impacts of social determinants of health on, you know, this wide scale level. And to that end, there are a number of things that we've done at ACC, which is, you know, first of all, create a health equity task force that, you know, its primary responsibility initially was to really kind of look through the college and see where are our health equity efforts and where could we actually, you know, sort of promote a little more. And to that end, over, you know, a few years' time, it actually developed into, you know, the organization has realized the importance of this. And now this task force has become a full, like, permanent committee that we are now, you know, actively pursuing health equity initiatives across the college. So I think that's great. We continue with the DEI initiatives in terms of making sure that people in underrepresented groups are also heard and included. And this actually is not just, sort of from the patient level standpoint, but we're talking as it, sort of transcends the entire cardiology or, medical community. And so we are very interested in the workforce inclusivity program that we developed, which actually supports people to go on to become future doctors and healthcare allied professionals. And so it's a really 360 program that we are involved in terms of the policy. And then to add to that, we also have a wonderful advocacy group that goes to the Hill every year. Actually, we have our legislative conference coming up to advocate for these health equity initiatives, as well as various things that actually affect clinician well-being and things that are so important to what we do on an everyday basis. Globally, we collaborate and work with the World Health Federation. There's also a number of other organizations, such as we're a partnership with the non-communicable disease reduction program with the World Health Organization. And we continue to have chapters, global chapters or international chapters in various countries that are thriving and growing. And so we are really trying to sort of expand the fingerprint, as well as to make sure we can improve health care for all, which is part of our mission.
Excellent. Excellent. This has really been a very, very rich discussion, and we're getting close to the finish line here. So in the next few minutes, and I really mean few minutes, I'm going to ask each of you to take just 1 minute or less to give us your words of wisdom, especially the words of wisdom that you would like to share with the webinar participants as the most important take-home message from our discussion here. And I'm going to begin with you, Glaucia. What's your 1 minute words of wisdom for our participants?
I think that CVD mortality is so complex, and social determinants of health is also so complex that maybe the SDI is not capable, although it's very good, it's not capable to resume all the impact of social determinants of health in CVD mortality. And I think that, as Melvin told us, is very important to join force to change the CVD mortality around the world. I think that's my thoughts, my final message.
Important to join forces, really, really crucial. Rosanne, what would you say?
I would say that cardiovascular health has a lot to gain from addressing social demographic inequality as well as social determinants of health. The report illustrated that national wealth determines the wider set of forces and systems shaping the conditions of cardiovascular mortality risk between the countries. And as we discussed today, that within countries, social determinants also play a significant role in cardiovascular health. The social determinants, just like any of the risk factors for cardiovascular disease, are complex, interconnected, and can group together. It's best to address them simultaneously. Ultimately, we need a comprehensive approach that combines policy and interventions to address social determinants across the life course. Individual level risk management, community level primary prevention, and health system strengthening should occur simultaneously. And I am very excited about social prescribing because there is beneficial evidence in low, middle, and high socio-demographic index countries, and for a wide range of subpopulations. It's a really good example of a solution that leverages existing health, societal, and community systems.
That's wonderful. So don't let the complexity scare you away. We need to have comprehensive approaches. I'm reminded of Jeffrey Rose's approach to sick individuals and sick populations. We need to be doing both. Eugene, what would you say? Your final words of wisdom?
It's hard to follow these exceptional thoughts that I've just heard, but I think obviously as a preventive cardiologist, I think we need, of course, the contextual relationship between the social demographic factors and the interplay with prevention and cardiovascular disease is critical. However, I think what we really need to emphasize, which I probably should have articulated at the beginning, is what are those primary risk factors that we need to talk about? And so we did mention hypertension, obesity, but in general, what we're seeing is the growing cardiometabolic disease trends, not just in the United States, but globally. So how that influences rates of hypertension, dyslipidemia, chronic kidney disease, obesity, and then things where we've had some success in parts of the world, including tobacco cessation and reducing tobacco use. So there are some areas where we've done better, and there are some areas where we clearly have opportunities to grow. So I think we need to recognize that while we focus on social determinants of health and these factors, in reality, we really need to be thoughtful about how do we manage the hypertension, diabetes, dyslipidemia, obesity, tobacco use, alcohol consumption, physical activity, because without recognizing how they interplay with the things we've talked about, we really are not going to be able to make that much of an impact.
Extremely important. Melvin, final brief words of wisdom for us.
Got the hardest one, the last one. No, no, I want to take it to the level of the patient. I think one of the things that we really need to try to do is connect all of this information that we discuss on the health equity level, the social determinants of level, the global level. We all need to connect that to the patient's lived experience. And, after having a health scare last year, I can't tell you how much being a patient and the lived experience is not, what we're doing is not translating to that level. And so we have some work to do. I think that we all have the same thing in mind. We all want people to feel better, live longer, be healthier. But in order for us to do that and to manage these things on a global population or community level, you have to basically embrace the patient's lived experience and understand what it will take for her or him or them to change.
Excellent. A patient-centered approach to the patient's lived experience put within the context of the community. So there you have it, ladies and gentlemen. I hope you've enjoyed this webinar as much as I have. And as we bring the session to a close, I would like to extend my very heartfelt gratitude on behalf of the organizing team and our sponsoring entities. First, let me offer my sincere thanks to all of the four of you, distinguished panelists, for generously sharing your expertise, your time, your perspectives on the critical roles of socio-demographic factors in cardiovascular health. It's very clear that your knowledge and your expertise have provided us with very actionable strategies to address the disparities, the inequities, and help improve cardiovascular care globally. I'd also like to express my appreciation to the staff of the Journal of the American College of Cardiology, Taryn and David and colleagues. Your dedication and hard work behind the scenes have made this event seamless and successful. And finally, a big thank you to the journal, JACC, the American College of Cardiology, and the National Heart, Lung, and Blood Institute, and all of our sponsors whose support has been invaluable in making this event possible. Your partnership allows us to continue to foster important discussions like what we just had today and help drive change in global cardiovascular health. So thank you all for being a part of this important conversation, and we look forward to continue these efforts with you together as we chart the future. So thank you and have a wonderful rest of the day.